Well, giving continuation to our endocrine reproductive drugs, let's move to male reproductive drugs topic. And this kind of time is going to be easier because many of the drugs we've seen in the previous topic is going to be repeated here. Starting by the slide where it's showing again that the gonadal releasing hormone secreted by the hypothalamus is the only hormone responsible for the control of the release and synthesis of LH and FSH by the anterior pituitary. And we see here highlighted in men what are the effects of those hormones. LH is responsible for the testicular Leydig cells to stimulate the synthesis of testosterone. And the FSH has this gametogenic function, which is to stimulate the Sertoli cells to produce nutrients for the sperm maturation. So let's just give a quick look at the androgen synthesis and distribution, because we're going to be seeing some of those compounds intermediary here cited during our lecture. So everything starts off with the cellular cholesterol, right? That has this steroidal main structure. And then that is transformed into testosterone by a sequence of two important enzymes, which will be the 17-alpha hydroxylase that will be transforming progesterone and pregnenolone to ultimately to the form of testosterone. So testosterone is the major androgen secreted. It circulates bounds to the sex hormone binding, which is SHBG. The remaining part of it is bound to albumin, and only 2% is available to bind to the intracellular receptors. Has a very poor bioavailability due to a high pass metabolism. And he is just calling attention for the formation of those 17 alpha hydroxylated derivatives. And the weak androgens, which is the dihydroepiandrosterone and androstenedione. So testosterone secretion and metabolism. Here on the right-hand side, you see the molecule of testosterone, right? That we just saw how it is synthesized. So once testosterone is released in the body, it can be transformed into inactive metabolites or active metabolites. The inactive metabolites is androstenedione and acetylcholinesterone. But there are also active metabolites, and they are very important, which are the dihydrotestosterone that is produced by the action of the 5-alpha reductase and the formation of estradiol, which is by the action of aromatase. So we will have drugs that blocks those enzymes, and by doing that, they promote an increase in the levels of testosterone. So on the left-hand side here, we see the measurement of serum testosterone in the levels of nanograms per deciliter, and we see that during gestation, infancy, and childhood, the levels of testosterone oscillates between 0 and 250, then go almost zero during big part of the infancy and childhood, and then it peaks around 13, 12 years old during the puberty, and then along the adulthood, it decreases slowly. So what are the physiological and pharmacological effects of testosterone? Well, testosterone will have their direct effects binding to the androgen receptor, which is basically development of the internal genitalia, also to increase mass and strength of the skeletal muscle during the puberty, as well as erythropoiesis and bone growth. And looking to the sides here, we see the production of those two active metabolites, dihydrotestosterone and estradiol, and showing their effects. The hydrotestosterone, when binds to the androgen receptor, promotes differentiation of the external genitalia, the hair follicles, and increase the growth during puberty. And estradiol binds to the estrogen receptor and is mainly responsible for the closure, the epiphyseal closure of the bones, and the increased bone density, as well as the stimulation of the libido. So how testosterone works is a bit different from estrogen receptor. If you remember, estrogen receptor are located inside the nucleus. So the estrogen has to cross the external membrane, go into the cytoplasm, and then go into the nucleus. But testosterone, the receptor for testosterone, which is the androgen receptor, they are located in the cytosol of the target cell. And they are normally associated to those heat shock protein, and they have to translocate into the nucleus in order to promote the changes in the transcription of a series of elements that we call androgen response elements, just like we saw for estrogen response elements. And that will determine the production of specific proteins according with the target cell that testosterone binds to. So what happens when you have androgen deficiency? If it's during the gestation, the fetal development will be compromised by an incomplete sexual differentiation due to a deficiency on that enzyme that we saw, the 17-alpha hydroxylase. There will be also potential androgen receptor mutations that can occur that can lead to spinal and bulbar muscular atrophy. And it also can see some severe forms of androgen receptor abnormalities that can produce absence of androgen action and a female phenotype. If the deficiency occurs before the completion of the puberty, then all the pubertal changes, including those related to external genitalia, hair, sexual hair, muscle mass, voice, and behavior, will be impaired to a degree that will be proportional to the abnormal levels of testosterone. And if the deficiency occurs after puberty, the degree of testosterone deficiency is substantial, and there will be libido and energy decrease very fast. But testosterone dependent characteristics will decline slowly, such as muscle mass, hematocrit, hemoglobin, and bone density. So, should not come back this answer here. So, how to treat androgen deficiency? So, we just saw that testosterone give origin to dihydrotestosterone, right? So that could be a possibility. And there's also this methyl testosterone, there's an alkylated androgen. And we have the testosterone enanthate, which is a testosterone that has an ester linked to it. So the difference here are the type of testosterone that I'm giving, right? So the answer will be testosterone ester. Why? Because testosterone orally will be quickly metabolized during the first pass by the liver. Same thing will happen with dihydrotestosterone given orally. And the alkylated androgen also will be easy to be metabolized. But testosterone enanthate, which is an ester, is a molecule that is designed exactly to bypass the hepatic metabolism of testosterone. Okay? So we're going to be using synthetic androgens. And like we saw, the main ones will be testosterone esters that could be propionate, enanthate, undecanoate, and cypionate. And like we mentioned before, the purpose here is to prolong the absorption time and promote a longer duration of activity. Also can be used derivatives of alkylated at 17 alpha position. Those can be given orally, but they are hepatotoxic. And those are also as drugs that we know nowadays that were developed trying to increase the anabolic effect of the testosterone, and they are known as anabolic steroids. And finally, we also have the transdermal androgens that can be given as a transdermal patch or a gel to avoid as well the first pass inactivation. They are more stable than testosterone. They promote more stable testosterone concentrations because they are being released slowly. And remember here that you also have the selective estrogen receptor modulators that can have some androgenic effect. And here on the right hand side are some androgens preparations that are available in the market and showing the ratio between androgenic and anabolic activity. So what are the uses for the androgens? So the first and most important indication will be male hypogonadism. So the goal will be to mimic as close as possible the normal serum testosterone concentration. And that has to be drug monitored. During the puberty, you should use lower dose than the dose used for adults because you don't want to cause the closure of the epiphyseal plates like we see here on the top. There is a time that those plates will be closed normally. You don't want to expedite that process. But in adults, which the symptoms are reduced libido, erectile dysfunction, reduced energy, depressed mood, and so forth, those low testosterone levels associated with the symptoms may warrant the hormone replacement for men as well, just like we see in postmenopausal women with the hormone replacement therapy. And there is also use for gender affirming masculinizing therapy. So here on the left hand side is showing the benefits of the testosterone replacement therapy, which we saw the symptoms: depression, increased risk of EG and low libido, which is erectile dysfunction, increased risk of osteoporosis, increases risk of Alzheimer's. So once the the patient started with the testosterone replacement therapy, then that will promote a better mind, more confidence, healthy heart, strong erections and healthy libido and so forth. And here on the right hand side there is a table showing different types of testosterone that can be used for replacement therapy and the different routes of administration that you can find. Topical gel, topical patch, intramuscular, oral, sublingual, and just oral. So therapeutic uses continuing. So the first one is hypogonadism, right? But then you also have catabolic states where the anabolic activity can decrease the muscle wasting and increase the erythropoiesis. Enhancement of athletic performance, and that will be basically androstenedione and dihydroepiandrosterone, DHEA, which are treated by the FDA as nutritional supplements, and they are not regulated by the athletic organizations. They can be also used in gynecologic disorders, like reduction of the breast engorgement postpartum. There is a weak androgen known as danazol that is used for endometriosis treatment, and also in combination with estrogen for replacement therapy during the postmenopausal period. There were previous uses, but they are not, they were substituted for newer drugs. Androgen's adverse effects, they are largely more seen, noticeable in women and pre-pubertal children, which will be masculinizing actions. In women, you're going to see hirsutism, which is the hair grow in the areas that are typical of male growth, acne, amenorrhea, clitoral enlargement, deepening of the voice, increased susceptibility to atherosclerosis due to the alteration of the lipids, which is basically the increase in the bad cholesterol and the decrease in the good cholesterol. In men, the side effects most common are acne, sleep apnea, erythrocytosis, which is the increase on hemoglobin and hematocrit, and gynecomastia. Some may show psychological effects as well, like what we call the roid rage with psychotic reactions. And the 17-alkyl substituted steroids are frequently associated with hepatic dysfunction. Contraindications, they should not be used in infants and young children because there will be deleterious effects on the central nervous system maturation, sex development, especially in females. During pregnancy, patients with carcinoma of the prostate or breast should be given a special caution if required to be given to children, and administration to patients with renal or cardiac disease. We also have, like we saw for estrogens, we also have anti-androgens. And as opposed to the use of androgens, they have many indications, and they are basically divided in two categories. Drugs which the mechanism inhibits the testosterone secretion, or the ones which the mechanism of action inhibits the testosterone action. So basically, the ones that interfere with the secretion will be the ones that are acting in the hypothalamic and pituitary release of those hormones. And the inhibitors on testosterone action will be somehow inhibiting or reducing the effect of the binding of testosterone to its receptors. And the clinical use for antiandrogens will be basically metastatic prostatic carcinoma and hirsutism. So here on the right-hand side, we have the 5 classes of drugs that we're going to cover that are antiandrogens with their site of action. So the number 1 will be the competitive inhibition of the gonadotropin releasing hormones. And so they will be antagonists, right? But you also can have agonists that, if given in a pulsatile administration, they will be stimulating. And if they are given in a continuous administration, they will be inhibiting the secretion. We also have drugs that decreases the synthesis of testosterone in the testes, which will be ketoconazole and spironolactone. Drugs that inhibits the 5-alpha reductase, so reducing the levels of reducing the levels of dihydrotestosterone, and that will be finasteride. And we have drugs that have a competition to bind it to cytosol androgen receptors. And we're going to cover each group right now. So this group here we already spoke about, goserelin, afarilin, and leoprotide. They are gonadorelin analogs, which when given continuously have, as opposed to pulsatile, they are effective in producing gonadal suppression. And in this case, they're going to be indicated in the treatment of advanced prostatic cancer and precocious puberty, as well as benign prostatic hypertrophy. And here the same table again for you to look at. And we also have the gonadorelin antagonists that we also showed in the previous topic. And we see here down a Barrelix, which is the one that has effect on male by extending the release form of the gonadorelin releasing hormone. And because of that, having this antagonistic effect, they are used to treat prostate cancer patients. And the side effects are like we mentioned in the previous lecture. Then we have a third class, which is the esteroids synthesis inhibitors. And the main example here will be ketoconazole, which is a non-selective inhibitor, not only of the gonadal steroid hormones, but also the adrenal steroid synthesis. So they do that by inhibiting many CP450 enzymes, the C17, the 20 lyase, the C11, which are all involved in the steroid biosynthesis. So by doing that, they block or they reduce or they inhibit the steroid synthesis. They also are capable to displace estradiol and dihydrotestosterone from their binding to the sexual hormone binding protein. By doing that, they increases the testosterone estradiol ratio in plasma. Five alpha reductase inhibitor, the main representative is finasteride. And if you think that dihydrotestosterone and not actually testosterone is the main androgen in the prostate, So if you inhibit 5-alpha reductase, you are reducing the levels of dihydrotestosterone, which is the main androgen in the prostate. So the indication will be as well to reduce the prostate size in the benign prostatic hyperplasia. Also giving low dose for male pattern baldness, and as adverse effects, gynecomastia and sexual dysfunction by decreased libido, erectile dysfunction, and decreased sperm count. They are also teratogenic if given to pregnant women. Then you have a group of 17-alpha hydroxylase and 17-20 lyase inhibitor, and the red arrows are showing where those enzymes are in that sequence of synthesis of testosterone down here. And as you can see, by inhibiting those enzymes, you'll be accumulating the previous substance in the sequence. So you're going to have an increase in progesterone and aldosterone, right? And there'll be also a blockade of cortisol, as we see here. So the example is abiraterone, and the main use will be the castration-resistant prostate cancer, and either as a first-line therapy or in conjunction with docetaxel, which is the drug first-line drug for treatment. What they do is to inhibit androgen production in the testes, in adrenal gland, and the prostate tumor cells. And they also inhibit the synthesis of cortisol precursors. So they should be given with the supplementation of corticosteroid. In terms of adverse effects, adrenal insufficiency, so you have to supplement with cortisol, and an increase in the levels of aldosterone. So that will be due to a buildup of pregnenolone and progesterone. So you might see edema, hypertension, and hypokalemia. So, and you also have the last group, which is androgen receptor inhibitors. The main representative will be from the MIDE family: blutamide, bicalutamide, nilutamide, and zalutamide. And what they do is to behave as a competitive antagonist of an androgen receptor. And by doing that, they are used to treat prostatic carcinoma and also to treat excess of androgen effects in women. This second group here are also indicated to treat metastatic prostate cancer. And there's a note here that I put on that is in your book, test book: chemical contraception in men. The testosterone, and in combination with danazol and medroxyprogesterone, were tested for contraception, but there were no reliable method. The drug that got closest was cyproterenone, but that does produce oligospermia, but they couldn't find a formula that could keep that stable. So there were no reliable method as well. So right now, pituitary hormones and gonadotropin antagonists are under studies. And finally, the gender-affirming masculinizing hormone therapy, which is basically the use of supplemental androgens to induce and maintain masculine secondary sexual characteristics. Judge administration is similar for the when you use for hypogonadism. And those are the targets: to thicker the vocal cords, to deeper the voice, to increase the facial hair growth, increase body musculature, body fat migration to more masculine pattern. As skin becomes oilier, so there's a possibility of acne, increased libido, enlargement of the clitoris, and cessation of the menses. And as a last group, the drugs that are used to treat erectile dysfunction, which is the family of afil, avanafil, sildenafil, tadalafil, and vardenafil. And the mechanism is to inhibit the phosphodiesterase 5. This, as we see here on the right-hand side, what it does is to transform the cyclic GMP into GMP, inactive. And by increasing the levels of cyclic GMP, it promotes smooth muscle relaxation. So by doing that, promotes vasodilation, and that promotes erection. Indications: erectile dysfunction. They are also used to treat pulmonary hypertension, and the rationale behind that is that phosphodiesterase 5 is a prominent in vasculature of the lung. So the same effect that we saw in terms of relaxation of the smooth muscle of the vase, you also will see that in the pulmonary vasculature, and that will result in a lower pulmonary vascular pressure. That's why it has indication to treat pulmonary hypertension. And the drug that has been used with that indication is tadalafil. Tadalafil is being used for benign prostatic hyperplasia. PGE inhibitors adverse effects, main ones: headache, facial flushing, bluish discoloration of vision, which is typical of sildenafil, and priapism. And very important to call attention of drug interactions, especially in male that are in use of organic nitrates or alpha blockers, because that will result in a severe hypertension that can lead to syncope or myocardial infarction. So they are absolutely contraindicated in persons taking nitrates. Lower dosing of the phosphodiesterase 5 inhibitors. For persons that are taking alpha blockers, there will be also a block of the signal to stop the erection, which is not good as well. And interactions with the strong CYP3A4 inhibitors that will increase the risk of hypotension, because they will let the androgens to perpetuate their effects. So this is our drug list, and we will be together on Friday, January 14, doing some exercises with those female and male reproductive drugs. Thank you.